Maura Kinney, Executive Director of the First Five Association of California. Welcome. Would you like to start?
Good afternoon. Thank you, Mr. Chair. Push it. Now we're good? Okay. Good afternoon. Thanks, Mr. Chair. I'm Dr. John Blake. I'm the Executive Director and the Dental Director of the Children's Dental Health Clinic in Long Beach, and I'm a member of the California Dental Association. We're a private 501c3 nonprofit dental clinic and teaching facility located on the Long Beach Memorial Medical Center campus. My clinic provides both routine and intensive dental services up to and including extensive dental treatment for special needs patients in the hospital operating room under general anesthesia, which is in fact where I was treating a patient for 4 hours yesterday. Each year we treat approximately 9,000 children enrolled in the DentaCal program from counties all over Southern California. Our programs for DentaCal patients are now firmly in the middle of a slow, painful, and quite destructive train wreck. We are trying to raise funds through private grants to cover our costs, which we can't rely on with any certainty, and which most dental providers don't even have the capacity to attempt. We've been lucky that our affiliation with Miller Children's Hospital allows us to teach and utilize University of Southern California's pediatric dental residents to help provide care at a reduced cost, another option that is not available to most dental offices. In cases where we need to send patients elsewhere for more extensive treatment, oral surgery, for example, we see families literally brought to tears on a regular basis because of the few options they have to receive these specialized treatments. Ultimately, the options that are available may include a waiting list that is multiple years long and traveling hundreds of miles. The state DentaCal audit confirms that these problems exist all over the state, and less than half the children enrolled in DentaCal, as we've heard before today, are actually receiving any dental care. We do have a few recommendations on how to change this. First, with regard to oversight by the Department of Healthcare Services, there needs to be criteria that allows for a legitimately accurate assessment of the true access to timely care. The state does not have an accurate directory of active providers in the network, and it does not account for the variations in locale, and it doesn't account for how many patients a dentist can actually treat in a given month. Furthermore, the state cannot simply rely on the mentioned 1 to 2,000 provider to beneficiary ratio, which was used in the state audit, because it assumes that each DentaCal dentist is able, and I'll say willing, to treat 2,000 patients within the system. The department needs to dig deeper. They need to determine which providers are truly active, and they need to determine how many patient appointments are available each month on a county basis. Our second recommendation is something that's been discussed, which is reimbursement rates. The audit highlights the role that reimbursement rates play and the lack of access for patients, and it should be clear as day that at this point that no real solution can be achieved without addressing the fact that DentaCal providers are incurring unsustainable losses in treating DentaCal patients. DentaCal reimbursement rates have only gone down the last 15 years, and it's just simply not reasonable in a state this large with a rapidly increasing DentaCal population, especially with the patients that have come in from healthy families. Rate increases would allow my clinic at least to partially pay our bills and serve more patients. Without rate increases, my clinic will be cutting critical services and staff and reducing comprehensive services. And I sold a private practice to take over this many years ago because I felt that children needed a little bit more of a break than they were getting. We've been serving Los Angeles County, the Children's Dental Health Clinic, for over 82 years. We've evolved from a sliding scale dental clinic, and then when DentaCal came in, we took on the program knowing that that's where the patients were that needed the most help. But that was back when you can at least break even in the system. And doing honest work in that system, the system just is truly broken. No doctor in their right mind would even currently sign on to DentaCal as it exists today. And I don't mean that to be flip. It's true. When you suggest a payment system such as it is, it does not make economic sense. As the audit points out, the rates paid for the top 10 pediatric services are a mere 35% of the national average. We propose raising these rates to the national average this year. We also propose reversing the 10% reimbursement cut implemented in 2013 for other dental services in both children and adults. While most pediatric medical services were exempt from that cut, pediatric dental services were not exempt. The state claimed at the time it would not impact access to care. The audit has dispelled that notion. Increasing reimbursement rates has indeed led to increases in utilization and network sizes in other states. Maryland recently provided targeted rate increases and increased the number of children receiving dental care from 44% to 64%. The state also saw a 62% increase in provider participation. Virginia increased its rate by 28% and increased the number of children receiving dental care from 24% to 56%, and the number of dentists participating increased 145%. The rate increases we propose for this year would be the strong first step, but quite honestly, much more will be needed to make a Denti-Cal a functional system. We believe that for a state to meet its legal obligations, at a minimum, Denti-Cal utilization needs to match the national average of utilization in the commercial market, which currently is 58%. That would be an adequate measure of California's compliance with federally mandated requirements, and we're at 43% right now. So for children right now in an adult program that just came back online this year, we have a lot of work to do. We ask that you please appreciate the urgency of this matter and the need for immediate substantive change. Most of all, my dental colleagues, they want to do the right thing and help patients. Thousands of competent providers have already fled the broken system, and I cannot blame them. California should continue to lead and innovate and not leave 50% of their population without access to dental care. This can and should be fixed, and I appreciate your time. Thank you.
If we can keep our comments down to 3 minutes if we can, the panel. Thank you very much.
I'd like to thank the Chairman and the members of the Joint Legislative Audit Committee and the Assembly and Senate Health Committees for allowing me to speak today. My name is Dr. Ron Inge. I joined Western Dental as the Chief Dental Officer last August. I have over 15 years of clinical private practice experience in California, several years of academic experience in one of our dental schools, and 15 years of dental benefits administration. These experiences have helped inform my current leadership role and guide my commitment to providing responsible, efficient, high-quality oral health care. Western Dental is California's oldest and most experienced dental and oral health services organization. We serve more Denti-Cal patients than any other provider in California, treating over 600,000 individual Denti-Cal patients last year. We've been providing quality dental care in underserved communities for over 75 years and pride ourselves on making dental care accessible for our patients. We have over 175 bilingual offices across California that all have expanded hours to help overcome traditional obstacles to obtaining dental care. Our team includes over 4,000 dentists, dental assistants, technicians, patient care coordinators, administrators, and clerical personnel committed to continuing this mission. As you know, a third of the state is now eligible for Denti-Cal, and half of our kids are also Denti-Cal eligible. According to one study, fewer than 1 in 5 dentists who accept Denti-Cal patients see more than 100 Denti-Cal patients per year. All of Western Dental's more than 700 dentists see much more than 100 Denti-Cal patients annually. We would like to see more Denti-Cal patients, but the state's provider cuts have simply made it impossible for us to provide the service that we have been promised, that has been promised to every eligible Denti-Cal patient. While the cost of provider care has risen dramatically since 2002, the state has reduced its rates below those 2002 levels. Adding a 10% cut on top of 2002 rates makes growing in the Denti-Cal unsustainable for Western Dental. The tragedy is that failing to fix the program translates into academic failure to many kids later in life. Children with poor oral health are 3 times more likely than their counterparts to miss school because of a tooth pain, according to the National Institute of Health. Nearly 28% of all children ages 2 to 5 have untreated tooth decay in their primary teeth. Among Latino children, the rate nearly doubles to more than 55%. Among African American children, the rate is more than 43%. Although the committee will explore various solutions to these issues today, one conclusion is clear. Preventive care is needed now to protect our kids and keep them in school. Providing full access this year and from now on will more than pay for itself in future dividends of a better education and job readiness for the kids who most need it. Thank you for your time, and I'm happy to be here to answer any questions the committee may have. Thank you.
Thank you very much.
Good afternoon, Mr. Chairman and members. I'm Jacob V. Hill with the Children's Partnership, and we appreciate this opportunity to share our views on the recent audit report of the Medi-Cal's dental program. Simply put, the audit report is one of the singular most important reports completed in recent years, and it merits continued serious attention by the legislature. With this report, we now have the facts and hopefully the momentum to address the longstanding problem of inadequate access to dental care for children in Medi-Cal. The report confirms what advocates and community providers have known for a long time, that children enrolled in Medi-Cal, who account for half of children in the state, are not receiving the dental care they need. It is time to explore real solutions to this crisis. We know that dental disease is the most common chronic health condition among children, yet it is largely preventable with regular preventive dental care. The state has done a poor job at getting that care to children enrolled in Medi-Cal. And the consequence of this neglect is that children suffer. It accounts for persistent pain, trouble eating and sleeping, missed school days, and expensive or unnecessary emergency room visits for preventable dental problems, which cost taxpayers. We commend you for focusing on the audit report and creating the opportunity to discuss solutions. The Children's Partnership supports the recommendations in the state auditor's report and has identified some tangible solutions that the legislature and the department can focus on that will make a real difference for kids. Firstly, at a minimum, the legislature should hold the department accountable for developing an accurate measure of dental provider network adequacy in the Denti-Cal program. Until the department produces a report zeroing in on where the gaps are, we won't be able to adequately address this crisis in children's dental care access. We recommend that your committees, perhaps in conjunction with the budget committees, require the department to complete an access assessment and report back to the legislature, perhaps following its May response to the state auditor. It makes sense to require the department to start with the counties identified in the audit report where there are an insufficient number of dental providers. With the report as a platform for such a review, that assessment should be achievable. That report should include the number of available providers who treat certain subpopulations of children who traditionally go without care, particularly young children and children with special health care needs. And it should also look at smaller regions within counties, knowing that county-based data don't always tell the whole story. And these elements should be reported in addition to the factors already being discussed, such as the number of current and new Medi-Cal enrolled patients a provider treats and the time it takes for families to get appointments and to receive care. Once these gaps are identified accurately, the department can work closely with stakeholders to identify and implement tangible solutions to address them. And because current stakeholder engagement hasn't been sufficient, the legislature should consider enacting a stakeholder requirement. Secondly, knowing that California can't possibly add participating dentists overnight, it's time to explore alternatives to traditional office-based dental care if children are to be well served. We recommend the state invest in the expansion of the successful virtual dental home to bring dental care to children in schools and Head Start sites. The virtual dental home has been rigorously evaluated and has been proven to be a cost-effective and safe way to bring high-quality dental care to children and others who may otherwise go without the needed care. The legislature and administration have already invested in the success of this model. Now it's time to identify a way to ensure the system can reach a critical mass and expand. And to that end, the Children's Partnership is co-sponsoring Assemblymember Lowe's AB 648 with the California Dental Association in order to identify a statewide source of funding to invest in the startup elements of the virtual dental home. And these could include training, equipment, and technical support. We know it's early in the session, but we hope you will support this bill as it moves forward. Additionally, critical to improving outcomes for this population is making sure that they're receiving community-based preventive care, family education, and care coordination. For example, the preventive service rule under the Affordable Care Act could allow for Medi-Cal reimbursement for cost-effective ways to provide preventive dental services, as well as other preventive health services in the community. We urge the legislature to urge the department to adopt this mechanism. And lastly, of course, reimbursement rates are an issue that can't be ignored. The legislature and department should explore raising reimbursement rates for providers who see young children. And we support raising rates for the top 10 services used by children to the national average, as well as the elimination of the 10% rate cut. But to be clear, we don't think that raising rates alone will solve these problems. To close, we believe it's critical that the department engage stakeholders in a meaningful way to develop and implement strategies to address the dental care needs of children. And we look forward to being constructive partners in helping the department and the legislature explore, shape, and implement solutions. Working together, there's genuine opportunity to ensure Medi-Cal's children get the dental care they need. Thank you.
Thank you very much.
Thank you. Good afternoon. My name is Moira Kenny, and I'm the Executive Director of the First Five Association of California. I want to thank the Chairman and the committees for their interest in this issue and for inviting me to add the First Five perspective. Oral health is a priority of First Five commissions for the reason that we are all here today. Oral disease remains one of the most prevalent unmet health needs of children in California. Last year, as we have for more than a decade, First Fives invested over $23 million to address this crisis, serving over 200,000 children statewide. With a mandate from the voters to enhance, not duplicate or supplant services, First Fives have from the beginning provided wraparound support for the bare-bones services reimbursed under Denti-Cal. Our oral health approach is comprehensive and includes parent education, preventative care, exams, treatment planning, restorative services, and even patient transportation. 70% of the Commission's funding oral health are working directly with Denti-Cal programs and providers to ensure that these essential benefits are maximized. The remaining 30%, importantly, are working in counties like the rural north, where, as the audit pointed out, there are few, if any, providers to support children. And we would argue that all of the children that we provide services to under First Five services are Denti-Cal eligible. As a result of our efforts, our commissions have long seen the shortages and challenges identified in the audit. Denti-Cal, however, has not been focused on the complexity of young children's needs. Last summer, we surveyed Denti-Cal providers across Southern California. Despite 90% of providers reporting that they were taking new patients, fewer than half were open to seeing young children. And only 1/3 of those providers were able to provide any sedation services to children in need. Given that many young children present with issues such as age, anxiety, or behavioral and developmental challenges that make serving them without sedation very difficult, the lack of sedation services essentially means that dentists cannot see young children. More routinely, issues such as parental knowledge, lack of transportation, the need for care coordination are the daily barriers that keep children from accessing the care they need, and as a result, keep our rates of dental disease so high. Our programs work to reverse these trends, educating parents and providers about the ways to successfully connect children to care. Over the past year, we have been in conversation with the department regarding these issues, and we sincerely appreciate their interest in solving the problems we and the audit have identified. My testimony today, then, is focused on thanking you for your attention to the issue. We offer our experience and our expertise to assist the department in both ensuring that existing benefits are accessible and, wherever possible, to ensure that these benefits are embedded in an integrated system of care that connects families to services, meets them where they are, and provides the education and support they need to follow through. In closing, since I see few families in the audience today, I offer the following testimony from a family in Orange County whose story illustrates that oral health services for young children cannot be successfully implemented without attention to the complex needs of young families. The Alley family in Orange County has 5 young children. The mother was unable to find a dentist willing to see her 3 youngest. By the time she connected the Healthy Smiles program funded by Orange County's Children and Families Commission, her 2 youngest children had dental disease so severe they needed general anesthesia. I'll let her tell the rest of the story. The staff at Healthy Smiles for Kids of Orange County provided caring treatment that reassured me every step of the way. Now, not only have my 2 youngest daughters received the general anesthesia they needed, but all 5 of them enjoy the dentist. The older ones remind their younger siblings to floss and brush, or else they will get cavities again. We at First Five believe that every family deserves the services that the Alley family in Orange County did. Thank you very much for your time.
Thank you very much for your testimony here today. We're going to open it up for questions from the committee. I want to pose the first question. This is to Dr. Blake. What do you think that the Department of Health Care Services should be implementing immediately to address this particular issue?
First on that would probably be making sure they have an adequate assessment of the providers and their capacity to treat. And just behind that would be rates. But if you want a primary one, they really need to know who's in the system, because I think the data is, one, old, and two, inaccurate to who's willing to actually see new patients with the current reimbursement level.
Thank you very much. One other follow-up question. Do you think if there was an increase in the rate, those areas that are not participating, do you think that there would be an opportunity for those doctors in those areas to participate in such a program and be successful?
So the short answer is yes on that. If you get an increase to the point where the docs, as Dr. Wood correctly pointed out, can at least pay the bills treating DentaCal patients, then many different providers will jump on board. I can add providers all day long as I can just break even on it. And so I think even in the rural communities, we're training residents that go out into these communities, and there's currently a disincentive for them to work within the system when they know they're not even going to pay their bills in it. So you bring it up to at least that level, and I think many providers, including rural communities, would be willing to come on board to help out.
Thank you. I think if I was working for the Department of Healthcare Services, I would want to collaborate with your agency and others to come up with a viable solution to address this issue. If I was them, that's what I would do. So we want to open up the floor for any members to weigh in on this conversation. Mr. Pan.
Thank you. So actually for Dr. Blake and also perhaps Dr. Inga, I know we brought this up once before in a prior hearing, but I understand that DentaCal rates are so low that many dentists find it less expensive, given the bureaucracy and the rates, to actually see these patients as charity care cases than to actually sign up, enroll, and accept DentaCal payments. So can you just very briefly comment on that, very briefly, because I do have some follow-up questions. I want to have time for that.
Sure. Just to that, you're correct. We have a network in the greater Long Beach area of dentists, specifically pediatric dentists and oral surgeons, that would rather just take a case. They no longer participate in DentaCal, but I know I can give them a call, and if there's urgent need, they'll take it. They just would rather not have to go through the hassle of the whole system, knowing that they're going to have to call multiple times just to get below normal reimbursement rates. So, yeah, that part is quite clear that they're no longer willing to do it.
And there are pediatric dentists in my community I've heard that from as well. So I think that speaks to how low the rates are and the associated bureaucracy. Yeah, the other question is, I know that as people are looking at utilization, and the finer points of utilization is really about the right care at the right time. But as a pediatric dentist, what is the standard of care in terms of number of visits, and at what age does those start? Because I think they made a comment about few dentists will actually accept them at 3 years of age, but my understanding as a pediatrician that actually the first visit should take place earlier than that. I can give the answer, but perhaps I'll let you provide that answer, and how frequently a child should be seen by a dentist for just regular preventive care.
So as a general public service knowledge here, first teeth, first visit, and so typically that's in the first 6 months of that child's life should be in, and it's just on mom or dad's lap or caregiver's lap, but yeah, that's when they should be in. And appropriate care, I would say, should be with the pediatric dentist who's trained to deal with that age group. Another side note, in the Greater Dental Society where we are, 17 different cities, there are now 0 pediatric dentists that will take a DentaCal patient. We're doing the only providing because we're using pediatric dental residents from USC, so you can tell who's jumped out of the system. These are well-intending pediatric dentists.
And then after the first year, how often should a child see a dentist for regular routine dental care? So
we're still, and it can be dependent on the child's caries rate or decay rate, but typically it's every 6 months. Yep, should still be.
Okay, so actually, relative to the standard of care, the utilization rate seems to be exceedingly low in terms of if we really want to do the appropriate screening and so forth. And when we look at utilization, while we're looking at very broad utilization rates, we should be looking at, for example, utilization at age 1, correct?
Correct.
And then probably utilization age 3, and in appropriate intervals. So, because ultimately it's not the utilization rate, it's are you getting the right care at the right time, correct? Thank you.
Thank you very much, Dr. Pan. We have Dr. Hernandez and then Dr. Woods.
Can you, I think this would be to either Dr. Blake and maybe even Dr. Ng from the Western Dental, because I believe you deal with a lot of Medi-Cal patients, correct, with Western Dental? Kind of tell me about how do you think the most efficient way to deal with it? In traditional Medi-Cal, we have transitioned from fee-for-service to managed care, whereas 80% of the patients are in managed care, 20% will eventually phase over. In dentistry, it's kind of flipped, and I know in Sacramento County, it's a lot of managed care, but there's been a lot of articles on the Sacramento Bee, how inefficient, how poor it is. In your opinions, what is the most efficient way to deal with dentistry? It seems how it's sort of unique than just general health care. Do you see it being more efficient through managed care and or through fee-for-service?
I think that there's a different answer to that question, because it isn't so much the efficiency in regards to the financial mechanism. Fee-for-service versus managed care, if funded appropriately, both can be successful. When either one is underfunded, then you have problems with either system.
So it's whether it's the higher capitation rate on managed care and or higher fee-for-service and reimbursement, then you're still going to get the problem resolved. So you think it's still the root of the problem is still the rate then?
Currently, the root of the problem is still the rate, but there are still quite a few other branches that would need to be put in place as well.
Okay, and do you have any response? I mean, do you have any thought? I mean, I don't have any answer, and I'm just curious because it just seems to be working sort of in the general overall health and Medi-Cal with managed care, especially with the COES and or the two-plan health system, and I wasn't sure in dentistry where was best utilized.
Yeah, in regards to that, I know we had some troubles actually in this county with regards to managed care as well as LA County in the Denti-Cal system, and an overwhelming population is by choice using fee-for-service to access their care. So I guess you have to really step back a little and look at how managed care translates into dentistry. And so the 15-minute visit with your pediatrician may be a little different than the needs of a dental patient. And so to give someone $5 for that visit knowing that they may need a root canal doesn't always equate. There would have to be some kind of hybrid component to the managed care side to actually make it work from a clinical standpoint. That's just speaking as a provider.
Okay, so with regard to the types of procedures, you think it's more efficient, or you're saying that maybe managed care isn't the most efficient way because of the risk you have to take when you get a capitation rate?
Correct. Yeah. I mean, it fits into a really neat financial box, but it doesn't work out at the clinical level currently in dentistry with some of the models that have been provided, and certainly, as Dr. Ian said, as the reimbursement rates or capitation rates.
So another question with regard to pediatric dentistry and the availability for children. I mean, how do we address this issue? I mean, do you have more residency slots for pediatric dentists? Do you look at increasing at a much higher rate for those individuals to get those individuals to take Medi-Cal? Any thoughts on resolving that problem or that workforce capacity issue?
Well, if you look at kind of what we had suggested, if you just take the top 10 utilized rates currently in Denti-Cal and made an increase in those are predominantly shifted towards preventative procedures, cleanings, sealants, x-rays, and such. So even at that level, if you took the younger pediatric population, what are you doing? You're hitting prevention, and you would hope there'd be an education component to that. So even if you just increased those top 10 rates, you would probably increase the access to care and make a difference in who do you want, the younger patients, so hopefully they're developing the good habits, so I'm not seeing them up in the hospital operating room at 15.
Right. Okay. So one final question, and this is open to the entire panel, and as an earlier question I asked and posed was, number one, distribution and access, and there's obviously certain counties that have very little to any dentistry. I mean, should we now look at where the greatest needs are, whether it's in inner city or rural, and not only just increasing those rates, but increasing them significantly higher to attract providers to go to those areas to address the greatest needs? Is that something that we as policymakers should look at, and maybe even look at teaching institutions. I think Dr. Woods mentioned, because what's going to happen, that cost is going to be passed on to the student, higher student loans and returns going to inhibit them from going out into private practice in these particular areas. Any thoughts on not only increasing the rates, but making it a significantly higher rate for those most neediest areas?
So this is Moira. I guess I would say that certainly the discussion that you're all having about rates is an important one and a significant one. But from the First Five perspective, we are serving children in those counties where Denti-Cal is currently not able to provide sufficient services. And we do it in the ways that Jacob suggested, through the virtual dental home, through providing preventative care services in WICs, in Head Starts. There are a number of ways where, when we're talking about preventative care services for the 0 to 3 population, we would encourage you all to be innovative and creative in the ways to ensure that it's not simply ensuring that we have a bricks and mortar clinic in every community, although that certainly would be a goal. But as we move towards that, as we rebuild the system, to think creatively with partners like the First Five Commissions, who are serving those children, are seeing them and providing significant services without the benefit, at this point, of having a bricks and mortar Denti-Cal clinic.
So you don't think that it's necessary brick and mortars, it's just being more innovative and figuring other ways, like the dental home as well? I mean, would you agree with as well, or do you think there's some merit to encouraging more individuals to go in those particular areas?
All solutions are awesome. I mean, yeah.
Okay. All right. I mean, thank you. Or unless anybody else has any comments. Thank you.